Good afternoon, everyone. Welcome to the Art of Art Symposium. This is a symposium that is a very popular symposium at the International AIDS Conference. My name is Jenny Hoy. I'm an infectious diseases physician from Melbourne, Australia, and my co-chair is Serge Hiholi from the Côte d'Ivoire. At this conference, we've already heard information on new antiretroviral strategies, for example, dual therapy for ART initiation. We've also heard about safety concerns of a particular antiretroviral drug in pregnancy. And this afternoon, we're going to hear from 4 speakers on a range of antiretroviral topics. I'll hand over to my co-chair to introduce the first speaker.
Thank you, Jenny. I'm Serge Hiholi, infectious disease specialist based in Côte d'Ivoire. It's my pleasure to introduce Linda Sanishimanda, Zimbabwean pediatrician advocate for women's health. He will focus on HIV. Linda is a senior lecturer at the University of Zimbabwe College of Health Sciences and led the North Clinical Research Site in Chitungwiza. I'm trying to pronounce some words in Zimbabwe, so pardon me. And conducted NIH-funded trials with the Impact network where she shares the President Scientific Committee. Based on involvement in pregnant women, she will give a talk on art and pregnancy. Linda, you have the floor.
Good afternoon, everybody. I'd like to thank the conference organizers for the invitation to speak today about ART in pregnancy. And I have no conflict of interest to declare. But I do have a question for the clinicians in the room. Have you ever treated a client whose story touched you so deeply that it stayed with you throughout your career? Well, I was fortunate to meet an extraordinary woman who we'll call Shamiso at the beginning of my pediatric career about 20 years ago in Zimbabwe. And I deliver this talk in her memory. Shamiso was a woman living in Zimbabwe who was diagnosed with HIV when she registered for antenatal care at the local clinic. I met her when she came for her monthly checkup with her beautiful chubby baby with cheeks like this and was breastfeeding voraciously. Shamiso had a CD4 count of 5 and I had no treatment to offer her. We had no access to ART in those days for treatment or for treatment as prevention, no viral load monitoring or early infant diagnostic tests. We had cotrimoxazole and short course zidovudine for prophylaxis, along with a healthy dose of advice about healthy living and how to feed her baby. And Shamiso probably knew a great deal more about that than this naive clinician who was sitting on the other end of the table. Shamiso faced stigma, partner violence, health-related anxiety. Sadly, she got sick with TB and demised. And I tell you her story today because Shamiso reminds me of how different things are now. Having access to ART has changed so much for women with HIV. It's revolutionized our pediatric wards, but many things remain the same. And the current system still fails to meet the needs of many of our women living with HIV. I thank Shamiso for all she taught me and all the clients and study participants who generously share their time and experiences to help us begin to learn about how to address these needs. And now I'll begin my talk with a few figures to illustrate about how many people we're talking about. 52% of adults living with HIV are women. That's 18.2 million women by current estimates. About 10% of a woman's life, her adult life, is spent pregnant or breastfeeding. So 1.1 million pregnant women were in need of ART last year. The figure on the slide shows a gradual increase each year in the coverage rate of pregnant women who receive ARVs for PMT-CT, and 80% of pregnant now receive lifelong ART, which benefits both mother and child. It reduces peripartum and postpartum transmission of HIV, such that we're on the path to eliminate pediatric HIV by 2020, at least in some countries of the world. As you can see from the graph, the number of new HIV child infections peaked in the late 90s and early 2000s and has begun to fall, while the number of infections averted is increasing each year. Lifelong ART also safeguards maternal health, and data from the PROMISE study revealing that it halves the rate of WHO 2 and 3 conditions among young, healthy women with high CD4 counts compared to women taking ART treatment as prevention, which we used to call option B. Toxicity rates on study were low, but virological failure rates were high at 23%. However, access is highly variable across and within regions, as you can see from the blue graph on the left, for different regions of the world. And this red graph on the right of the 23 focus countries, mostly in sub-Saharan Africa, where 4 countries reached the target of 95% of pregnant women receiving ART. A sobering statistic is that 80% of new pediatric infections were recorded from the other countries that had not reached that target. Retention in care and adherence to ART remain challenging, even where women are receiving lifelong ART. A recent meta-analysis estimated in the B+ era pooled retention at 12 months postpartum to be 76%. In Malawi, among postpartum women retained in care, only 30% demonstrated adequate adherence during the first 2 years on ART, and in Cape Town, sustained viral suppression to 12 months postpartum only occurred in 70% of women, even though they were in care. Common factors associated with disengagement from care have emerged across studies, and qualitative reports have highlighted themes that constantly emerge relating to the fear of disclosure, social discrimination, logistical barriers to care, including finances, transportation, and time commitment. So practitioners and policymakers have a lot more work to do to meet the needs of women on ART at this particular time in their lives and break that barrier to care. The peri- and postpartum period also has a high risk of incident HIV infection overall, with a rate of 2.97 new infections per 100 person years in late pregnancy and a staggering 4.18 per 100 person years in the postpartum period. Incident infection increases the risk of transmission to the infant, some series showing a 9 to 15-fold increased risk, illustrating why HIV treatment and prevention for pregnant women should be a priority across the globe. The optimal universal ART regimen should achieve rapid and sustained viral suppression to improve maternal health and prevent transmission to the infant and the subsequent infant. It should be well tolerated, which can be tricky in women who often feel nauseous, have a high threshold for viral resistance, favorable drug-to-drug interactions, as women will need treatment for other conditions such as TB or malaria and could choose to take hormonal contraceptions. The ideal regimen needs to be affordable for governments and the community and be safe for mother and baby. And here's where I reflect back on the day when I first met Shamiso about 20 years ago. Our current efforts are suboptimal, and I read from a 2017 publication. Selection of an appropriate ART regimen in pregnancy requires consideration of regimen efficacy for maternal health and prevention of vertical HIV transmission, pregnancy pharmacokinetic changes, as well as maternal and fetal safety. Considering that ARVs have been prescribed for pregnant women for more than 2 decades, the paucity of data relating to the efficacy and safety for pregnant women and their ARV-exposed children is striking. And an insightful review published last month, the biological mechanisms that underlie observed associations between antenatal ART and adverse outcomes in pregnancy and birth are not completely understood, with further research needed as well as strengthening of the systems to assess safety of antiretrovirals for the mother and the HIV-exposed child. In the treat-all era, as duration of treatment and options for ART expand, pregnant women will remain a priority population for treatment optimization to promote their health and that of their ART-exposed children. Yet we're faced with a situation where we just don't have the safety data we need in this population for risk-benefit decisions to be made. There has been a repeated call to action, even here at this conference this week, to improve the current system, which is failing women, because in this regard, not much has changed since the day I met Shamiso. We know that toxicity of a drug is important in early pregnancy, for any drug, ARVs included. And it's always a trade-off between the benefits of treating a serious condition in the mother and the risk of harm to the fetus. I'd like to draw your attention to this graphic, which shows the stages of development of the organs inside a baby's body after the time of fertilization. The red box outlines the period of organogenesis, which is between weeks 3 and 8 after fertilization, the time when the fetus is most sensitive to teratogens that can affect the way a body organ develops. Generally a very rare event that requires large numbers of women to take the drug before we can identify agents that increase that risk of a certain defect. And this all happens very often before the time a woman realizes she's pregnant. Okay, confession time. It took me 16 weeks before I realized I was pregnant the first time around. Okay, I know. Clueless, but moving on. Next slide. There are physiological changes in later pregnancy that could affect ARV levels, potentially impacting safety and efficacy of ART. There are changes in absorption, distribution, metabolism and elimination, producing, as an example, using tenofovir, a 20 to 30% reduction in drug levels circulating in the mother's blood during pregnancy. Now, the Impact P1026S protocol team has developed particular expertise in this area and pharmacokinetic studies of ARVs in infants. However, collecting PK data in an opportunistic manner, once these new ARVs are already out there in use, being swallowed by pregnant women, is never the ideal situation. ARVs may increase the risk of adverse pregnancy outcome, including preterm delivery, fetal loss and stillbirth, low birth weight, neonatal death, and infant anemia and lactic acidosis due to the exposure to the drugs that the mother takes. As we sit here today to hear about the state of ART, about new drugs in development, let's reflect on Shamiso's story and what barriers still remain for safe and effective use of ART in pregnancy, of care of a woman throughout her life course. And I'll leave you with one that requires input from all the parties present. Although ART has great benefits, including prevention of perinatal transmission and saving mothers' lives, surveillance systems to enable early detection of signals of potential adverse effects are needed to assess the safety of new drugs in pregnancy and women of childbearing age. I'd like to acknowledge once again the conference organisers and the community of women living with HIV, as well as my network Impact and all those who have given me inspiration for this talk. Thank you.
Thank you, Linda. We have time. If you have any burning questions, you can take one question if you have one. Okay, that's clear. So we know, all of us, that we need to have the best art in pregnancy. There's no doubt about that. Okay, next speaker is Leticia Perez-Salem, right? Okay. She's an infectious disease physician, internal medicine department of Specialties Hospital of Siglo National Medical Center in Mexico. She has published widely on HIV, ARV treatment, and adverse effect of art. We are moving now from Zimbabwe to Mexico, and I think that it is the same space. And she will speak about sequencing strategies in resource-limited countries. Leticia, you have the floor.
Thank you. Good afternoon. Thank you for the organizing committee to invite me to speak to you today about sequencing strategies in resource-limited settings. These are my disclosures. ART in resource-limited settings poses many challenges. Although access to treatment in this setting has increased in the past decade and has been associated with a decrease in HIV morbidity and mortality, the majority of patients in resource-limited settings are still initiated in efavirenz-based regimens. There is limited access to viral load monitoring, which delays the diagnosis of viral failure and subsequent change to second-line regimens. An estimated of 3 to 20% of patients in resource-limited settings are already receiving a second-line ART. Different factors have been associated with the efficacy of these regimens, including adherence and resistance. Current WHO guidelines recommend a second-line regimen based on a boosted PI and 2 NRTIs after failure of an NNRTI-based first-line regimen. These are the main studies that evaluated second-line strategies. They all compare lopinavir-ritonavir plus 2 or 3 NUCs versus lopinavir-ritonavir and raltegravir in 3 of the studies, darunavir-ritonavir and TDF-FTC in the 2 latest study, and the most recent one, dolutegravir plus 2 NRTIs, which the results for the 48 weeks have been presented in this meeting on Monday. Failure had a different definition in each of the trials, as you can see. All of the studies included patients from sub-Saharan Africa, and 3 of them included patients from middle and even high-income countries such as the second line, including the UK and Australia. In only 2 of the studies, the second line and the Downing study, the treating physician had access to genotype results to guide the backbone NRTI regimen. All of these studies, except the Downing with dolutegravir, show non-inferiority. The EARNST study had a third arm in patients that included 12 weeks of the combination of lopinavir-ritonavir plus raltegravir followed by lopinavir-ritonavir monotherapy. And this arm, shown in blue, show a worse outcome than the first 2. Interestingly, when they compared the number of active NRTIs in this study, they did not find a difference if they had activity in 1 or 2 drugs, and even a worse outcome when they received 2 or 3 NUCs, mainly associated with toxicity and intolerance. In the Downing study, they also compared the impact of the backbone of NRTIs. Stratify if they did follow WHO recommendation for the sequencing of NRTIs. That is, if they were coming from a tenofovir backbone, they will be switched to ACT and vice versa. And as you can see in the graph, in every analysis, when they did follow this recommendation, the outcomes were better. They did not find any difference if they were coming from a first-line regimen based on tenofovir or ACT. ACTG 5288 was presented earlier this year at the CROI meeting. And even though it was designed for a further along third-line regimen, they did have an interesting core A, which accounted for 53% of the patients enrolled. And in this cohort, patients did not show any resistance to lopinavir-ritonavir, or at least they have one susceptible NUC, both. And even though this cohort had the best resistant profile, it was the cohort that did the worst outcome. It was a cohort that was associated with more percentage of viral failure that even increased over time, as you can see in the graph, and also was the arm that developed more new drug resistance mutations. In this small study done in Nigeria, which evaluated the proportion of compromised drugs for a second-line regimen NRTIs, they stratified patients between two factors. If they were coming from an ACT or a tenofovir first-line regimen, and the time they were changed to the second-line strategy. If the patients were changed after the first 6 months of documented viral failure, they did show an important difference in the compromised drugs. And also, patients on the first-line regimen on ACT had 9.9 times higher odds of having compromised second-line NRTI options versus those coming from a tenofovir regimen. Pre-treatment drug resistance is an issue all over the world and also in limited resource settings. WHO reported the prevalence of pre-treatment NRTI resistance of 5.5 back in 2010. 20% of adults receiving ART for 6 to 12 months have unsuppressed viral load. And of those, 70 to 90% people with treatment failure on ART will have a drug-resistant virus. Pre-treatment drug resistance is increasing in middle and low-income countries. As you can see in the graph, Southern Africa, Eastern Africa, and Latin America have already reached or are about to reach the cutoff of 10%, in which WHO recommends to take an action, either to start with another kind of drug, mainly integrase inhibitors, or do a pre-drug genotyping testing. Here I show you the resistance in Mexico in a 5-year period time. Back in 2010, we had 4.2% of pre-treatment NRTI resistance. By the end of 2015, we have 9.2%. Latin America represents about 6% of the total people living with HIV/AIDS, and we are far behind 90-90-90 goals, especially for the Caribbean. Latin America poses many challenges, as we are a region of variability, great variability in healthcare systems, resources, and many other things. Most of the data come from two large cohorts: the Caribbean, Central, and South America Network, or CASANet, which has around 37,000 people following in 7 countries, and the Latin American Network Study Group, which reaches almost 100,000 patients in 11 countries. In this region, viral load monitoring is less than 2 measurements per year per patient, and costs vary greatly within the region, as you can see in the examples. Resistance testing after first failure is done in 84% of the cases, but resistance prior to the initiation of ART is rarely done. A third of our patients are exposed to medication stockouts episodes. Public financing is scarce. 30% of the patients now are still in their first-run regimen taking AZT, and an estimated of 10% of these patients are on first-line failure. As you can see in the graph, there are many regions and countries in the region that are still presented with a late HIV diagnosis with less than 200 CD4s. I would like to share to you the experience of Mexico. Mexico included HIV treatment as a national program back in 2001 and universal access in 2014. We do have a fragmented healthcare system, and HIV treating physicians had a broad range of expertise, varying from medical doctors right out of med school to ID physicians. National guidelines for the ART treatment were available since 1997 and were mandatory by the Ministry of Health in 2004 because there was a great variability of antiretroviral prescription without assuring efficacy. We have open access to almost all drugs except for integrase inhibitors, maraviroc, etravirine, T20, and darunavir. Those do require an evaluation from national committees. These committees were created in 2008 for the rational use of antiretroviral and to provide advice for HIV treating physicians. Although initially aimed for the rational use in multi-drug resistant treatment experienced patients, have now become a cornerstone advisory committees for different aspects in HIV treatment, like adverse events, simplification, earlier failures, and healthcare workers post-exposure prophylaxis. Mexico is estimated to have 230,000 patients living with HIV and AIDS, and 141,000 patients are already on treatment. Seroprevalence is 0.2 between the ages of 15 and 49 years, with pregnant women prevalence of 0.07. Higher prevalence, as you can see, in high-risk groups. Here I show to you results from the 2 main committees. In the Department of Health that takes care of 81,000 patients, 94% of which are on ART, the committee in an almost 10-year period had evaluated 2,870 patients, reaching a viral load suppression from 83% for the overall open ART prescription versus 80% in patients heavily ART experience evaluated by the committees. Over this 10-year period, the reasons for evaluation were 72% for viral failure and drug toxicity and simplification, other important reasons for evaluation. The Social Security system takes care of more than 40 6,000 patients. 92% are on heart. And the committee has evaluated, in the same time period, 3,800 patients. The reasons for evaluation in both committees do change over the years. And here I present to you only the reasons for evaluation in these 7 months of 2008, where viral failure only compromises 29% of the evaluated cases. Toxicity, simplification, drug-to-drug interaction, and pregnancy are other common reasons for evaluation. This experience in Mexico has allowed us to better optimize resources and facilitate the best art combination in each case according to a group of experts. In summary, the outline for antiretroviral treatment in resource-limited settings poses many challenges. We do have to deal better with medication stockouts, limitation in treatment monitoring, poor attention in care in some areas, fragmented healthcare systems, and funding constraints with increasing patient loads that pressurize healthcare systems. In conclusion, outcomes from the Ernst, Two-Lady, and SELECT studies suggest that resistant testing may not be required in patients failing a first-run regimen based on an NNRTI. Although if available, information of resistance mutation will be important for future regimens. The combination of lopinavir-ritonavir plus raltegravir is a safe option, as efficacious as a boosted PI and 2 NRTIs for a second-line regimen, although it has side effects and it might be inconvenient. Dolutegravir and 2 NRTIs appears to be superior to a boosted PI and 2 nukes, based on the Downing results. It has a better safety profile and lower cost than raltegravir. Even with documented resistance to NRTI, there is clear evidence that their role in rescue treatments. Viral failure in the presence of documented resistance suggests non-adherence and should be addressed based on the results of ACTG 5288. Advisory committees may have a role for optimizing resources while assuring optimal treatment in resource-limited settings. I would like to acknowledge all the people that helped me put up this presentation, and of course the patients that inspire our work every day. Thank you very much.
Thank you, Leticia. Is there any burning questions in the audience? No. Okay. So you have the floor now.
What we'll do is we'll have a discussion when all 4 speakers have had an opportunity to give their presentations. Our next speaker is Dr. Kimberly Scaasi from the United States. Dr. Scaasi is an associate professor at the University of Nebraska Medical Center's College of Pharmacy and College of Medicine. Her research program focuses on optimizing pharmacologic therapies for persons living with HIV, with an emphasis on global health and gender-related issues. She serves on the U.S. Department of Health and Human Services panel for antiretroviral guidelines for adults and adolescents and is a member of the NIH Office of AIDS Research Advisory Council. And today she's going to talk to us about new antiretroviral drug delivery systems. Thank you.
Thank you. I'd like to start by thanking the conference organizers for inviting me to share this very exciting topic at AIDS 2018. I'd also like to comment that I do not have any conflicts of interest related to this presentation or the long-acting or drug delivery systems that I'll talk about today. I'd like to start out with a slide to just show you all of the various drug technology devices that are emerging for drug delivery. Some of these are new and novel mechanisms, but some of them have been used for many years and decades, in fact, to deliver medications for other disease states, such as contraception or insulin delivery. Today I'm going to focus on just a few key technologies where we have emerging data related to antiretrovirals to illustrate the potential for these drug delivery systems to really revolutionize antiretroviral therapy administration. I'll also acknowledge that there's far more data in this field than I can adequately cover in this small presentation. So I'm going to try to focus in on some of the key broad areas for discussion. And I hope to use some of the data that are generated so far in the field of PrEP to demonstrate how these technologies could be used to demonstrate the future potential for a fully suppressive antiretroviral regimen to be administered via these devices. So with that context, I'm going to use the rest of my talk to really focus on how these drug delivery systems can help fulfill the promise of long-acting antiretroviral therapy. So before we had the data from the LATTE-2 trial, we had this early look at the interest of our patients in the use of long-acting parenteral nanoformulated products. And in this survey of predominantly African American men, we found 40 to 70% of participants suggested they either definitely or probably would be very interested in a long-acting injectable. If you notice, the questions to the right assess the interest as the frequency of injections or frequency of infusions extended from 1 week out to 1 month. And you'll note that as the frequency extended, there was greater interest in the drug delivery device. That led us to LATTE-2, and this is a picture of our study nurse in our clinic at Nebraska administering the 2 ml injections for the LATTE-2 study, either every 4 weeks or every 8 weeks. And I'll say from our site's perspective, we had strong interest from our local patients for participation in this study. So we now know that long-acting nanoformulated carbotegravir and rilpivirine was effective for maintenance therapy in patients living with HIV. Unfortunately, the study really tried to assess also the patient perspectives on the use of these injectable products in comparison to oral products. So first looking at the graph on the left, the first 2 bars represent the injectable formulations for either 4 or every 8 weeks, and then the third bar represents the oral therapy arm in the LATTE-2 trial. And the question here was, how satisfied are you with your current treatment, so the existing therapy? And it was graded on a scale from 0 to 6, 5 and 6 indicating very satisfied with the current regimen. And you'll note that across the arms, there's not a significant difference in the acceptability of the current regimen, either in the oral or injectable route. Secondly, they asked, how satisfied would you be to continue your present form of treatment? And here's where I think you start to see a little bit of a difference in the patients who continued receiving oral therapy versus those who received the injectable. And I would say this gives an indication that patients were highly interested in being able to transition to long-acting injectable products. So it's not always so easy to take the medications that we currently have available and make them into a long-acting formulation for use in these drug delivery devices. So this slide tries to give you some characteristics of products that have been successfully turned into long-acting products. So most of the long-acting formulations to date have been developed from existing oral formulations, and the benefit to that is that we have some existing pharmacokinetic data that are associated with outcomes that allow us to have a target for what we could achieve with the long-acting formulation. So we use some of those oral characteristics to describe kind of an optimal medication for use in these products. So you notice the 4 drugs that I've listed at the bottom are all currently available in a long-acting injectable formulation. When looking at the daily oral dose, all of them represent a relatively low oral daily dose that can achieve therapeutic concentrations based on that low daily dose. And then secondly, they all have what we would consider probably a medium to long half-life, so how quickly the body is going to eliminate the medication, which helps to allow the long-acting formulation to work together with the natural pharmacokinetics of the drug to extend the life of the agents. Fortunately, we also have drug development strategies that can help enhance these characteristics even further for use in long-acting products, particularly nanoformulation of these medications, making prodrugs, or adding these medications to devices to extend the duration of action. So turning for a moment to nanoformulations of these medications, in this recent review article, they highlight some of the characteristics of nanoformulated medications and how they improve antiretroviral therapy to date. So there's investigation in using oral nanoformulations to reduce the total daily dose required of medications, which could have cost implications by reducing the amount of total drug needed to provide effective therapy. Secondly, work is underway to provide targeted nanoformulated products that could use the altered physiochemical properties of the medication to target specific sanctuary sites, such as the brain or the lymph node, which may be hard for traditional medications to penetrate. And then thirdly, as we'll talk about today, the use of nanoformulations to really combine with some of the long-acting delivery mechanisms to provide long-acting medication to help improve the duration of time that a dose may be administered. So with that, I'll shift to 4 key devices that may be used for long-acting formulations. First, the product we're probably most familiar with is long-acting injectable products. Again, turning to the example of nanoformulated cabotegravir and rilpivirine, these 2 slides represent the pharmacokinetics of those 2 products when they were administered as a nanoformulated parenteral IM injection. The cabotegravir is represented in the green on the left, and the rilpivirine is represented in the blue on the right. And essentially, all of those lines with the individual dots represent the trough concentration of each of those medications when given via the injectable route. And this is in relationship to the reflective trough concentration of the oral formulation represented by the solid lines in comparison to the injectable products. Overall, you see that the injectable products maintain concentrations that were similar to daily oral products, which would be our goal with most long-acting formulations. Also notably, the bottom dashed lines in each chart represent the protein-adjusted IC90 concentration, which is the concentration we would hope to maintain the concentration over. And you'll note that there's a good cushion in between the trough concentration observed and the time before the patient would fall below that threshold suggested for effectiveness. So I'm not going to talk a lot more about long-acting injectables. I think Latte has demonstrated that that particular formulation worked for those patients, but I think there's some more questions that we need to work towards as a research community to help optimize this particular medication for all of our patients living with HIV. First, we have to be able to extend this information beyond adults to all persons living with HIV, including children, adolescents, and pregnant women. We need to make it affordable for all areas of the world that are affected by HIV to have access to these important products. Next, we have to work towards optimizing the drug dose and delivery to see if we can perhaps minimize the injection quantity or the frequency of administration to make this an even easier product for participants to use. And then thirdly, I'd lump a lot of things into general clinical management strategies that I think we're all used to managing patients in a clinical setting with oral dosing of medications that may slightly be different when we're giving a long-acting formulation. Particularly, how do we manage any side effects that may occur in an unremovable injectable product? How do we manage drug-drug interactions that may occur that would normally be managed with dose adjustment of an oral product? How do we manage that with an injectable product? And then there's a lot of conversation about how do you manage the long drug exposure after injections are complete, which is often called the PK tail. And so there's a concern that as you're not able to switch patients to another effective therapy, we have to be able to manage how we're going to discontinue therapy in patients so that we don't have a period of time with suboptimal drug exposure. Shifting from injectables to implants, I think implants, although earlier in the stage of development, offer an interesting strategy to address some of these limitations with injectable products. So I think our best example for an implantable device comes from contraception. So there are three forms of a progestin-containing subdermal implant that can be used to provide contraception over a period of 3 to 5 years after insertion. The implants are inserted in a minor sterile procedure at bedside, which is being conducted all over the world by nurses and other healthcare providers that have been trained on the insertion of these implants. The implants release a slow daily dose of progestin over a period of time, slowly declining over time, but always remaining above the concentration that we believe confers contraceptive effectiveness. Importantly, the implant can be removed at any time that the woman desires a pregnancy, and the drug is removed from the body within a short period of time, allowing the patient to return to fertility or to address any side effects that may have occurred. There's fortunately been a lot of ongoing work on the implementation of using antiretroviral therapies as part of a subdermal implant, specifically using tenofovir alafenamide. I've described 2 different implants that I believe I found in the literature that have been investigated using TAF to deliver TAF over a period of time. The PK curve in the bottom left-hand corner essentially tells us that the concentrations of the active tenofovir moiety in plasma and in intracellular PBMCs achieve adequate concentrations that would be associated with the prevention of HIV transmission, which provides some optimism. In the recent CROI abstract presented, they did note that there was some decrease in the tissue concentrations of drugs, particularly in the vaginal and rectal area, from the beginning of therapy over the course of the implant. So this is something that will need to continue to be worked out during drug development, but I think this indicates a really novel and exciting strategy. I think we also recognize that in order to eventually use these products as part of a fully suppressive antiretroviral regimen, we really need to have partner drugs to use in combination. So I offer this one example of MK-8591, which pharmacokinetically represents a drug that would be an ideal product for a potential long-acting formulation. And I'll also note that Merck is also the manufacturer of 2 of the contraceptive implants, so they have implant technology available that could potentially in the future be combined. So with that, I would offer that I think implants offer just what we know about them from contraception, offer a really promising strategy for truly long-term antiretroviral therapy beyond just a few months, but out to a few years if we could get the right products available. I've listed what I think of as some of the advantages and disadvantages with this product, and I will note that one of the significant disadvantages could be regulatory barriers, particularly if you're looking at a combination product that's really delivering multiple drugs, where they'll have to fulfill both drug and device requirements through the FDA and EMA. Moving next to an area that we're maybe more comfortable in, the area of antiretrovirals, there are some exciting long-acting oral products that could potentially be on the horizon. First, I want to give an example of how nanoformulation of an existing product can help with toxicities. So those of you who work with children will know that lopinavir ritonavir is in the liquid formulation, contains both ethanol and propylene glycol, which results in a warning for use in premature infants, and also just overall concern over the risk of these additives in children. This is a study that evaluated a nanoformulation of lopinavir ritonavir without those additives. And the PK curve on the left demonstrates the normal product, or the commercial product, and the curve on the right demonstrates the nano product in rats. The goal here is that it demonstrates that the achievable concentrations are similar between the 2 products, and actually even a little bit less variable in the nano-formulated products without the additive agents that could result in toxicity. The next is a nano-formulated example of the potential for decreasing drug costs through nanoformulation. This is an efavirenz nano-formulated product of 300 milligrams that was compared to the standard dose efavirenz product of 600 milligrams and resulted in similar PK exposure or even higher PK exposure, again suggesting that we could decrease the cost associated with the parent drug through this formulation. And then finally, I'd like to highlight a recent publication in Nature Communications just this year that demonstrates a really novel oral drug sustained release delivery system. So this is a product that when swallowed, it looks like a normal capsule. Once it reaches the GI tract in the stomach, it extends into a star-like product with 6 different rods. Each of the rods can be loaded with different medication products, which gives us the potential to release through multiple medications at various release rates, as is demonstrated in the lower right-hand graph. So we can achieve varying concentrations and different release rates through this one product. The recent publication tested this device in a swine model over 7 days, looking at dolutegravir, rilpivirine, and cabotegravir. So the top row of this demonstrates the immediate release product, or the commercially available product, and all 3 of the products reached undetectable concentrations within a day or 2 after administration. The lower row shows the PK over 7 days of these 3 drugs delivered via the sustained release device, demonstrating that there was sustained drug exposure over time. So although this is very early in development, I think it shows a very promising option for a fully complete antiretroviral regimen through an oral route of administration. And then finally, I'd like to wrap up just highlighting the use of the delivery device of vaginal rings. So vaginal rings are a very popular and important route of medication delivery for women who are at risk for HIV. And I think they also offer a really unique example of providing multiple drugs with multiple purposes from a vaginal ring device. So Multipurpose Technologies provides both antiretroviral medications for the prevention of HIV, as well as a hormone to provide contraceptives for women also at risk for HIV. And this is just a nice example of an area that has a lot of ongoing work. There's been a lot of different devices that have been developed to deliver 2 to 3 different medications at a time, and represents the future potential for these types of products. So in conclusion, I think that these drug delivery methods offer the potential to revolutionize how we provide antiretroviral therapy and hopefully improve the lives of all persons living with HIV. I've outlined some next steps on this slide. Specifically, we need to work towards extending the number of long-acting options that are available, and this includes developing new medications that can be used or modifying existing medications that can be added or combined to make a complete antiretroviral regimen. But all of this must be done in the context of making sure that these drug delivery devices are affordable and accessible to all persons living with HIV across all different regions of the world, as well as types of people living with HIV. As I've mentioned, I was not able to go into great detail about a lot of these products, but I wanted to leave you with one resource. This is an NIH-funded program called the LEAP, which is a long-acting and extended-release antiretroviral resistance development program. And this has a wonderful website that helps bring together people who are working in this field. And for those of us that are more clinicians and interested in keeping up on the field, there's a resources tab that keeps up to date on all of the emerging data in this very exciting field. With that, I'd like to thank my mentors, and particularly Sue Swindells and Courtney Fletcher, who shared many of their slides for this presentation. And I have to end with a special thanks and acknowledgement to all of those living with HIV who support and advocate for this work. Our fight against HIV and AIDS is indebted to people living with HIV, both past and present. Thank you very much.
Thanks, Kim. Our final presentation before we open it up to the floor for questions or comments is from Hans-Jürgen Stolbrink, who is a professor of internal medicine at the University of Hamburg in Germany. He is a clinician scientist who's been involved in HIV treatment, care and research since 1987. He's currently the scientific director of the ICH Study Centre in Hamburg, and he's a member of the German AIDS Society Steering Committee. And he's going to talk about new antiretrovirals.
Thank you very much. I'm indeed a Hamburger, so please. Thank you very much for the kind introduction, and let me thank you all for attending this session, and let me thank the organizers for inviting me to provide my clinical view of the recent developments in the field. These are my disclosures. And as a clinician, I'm asking myself, do we still need new antiretrovirals, given the very good tolerance and high efficacy of what we currently have in our hands? But definitely there are people, and that would be my priority very high on the list, who are failing with resistance, for whom we have no good means to re-achieve or achieve suppression. They would be the top priority, in my view, for developing new drugs. But there are other reasons as well. We might want to fortify a regimen against future failures and phases of low adherence by increasing the genetic barrier. We might want to provide switch options in cases of patients who already have archived resistance. We don't want to risk any resurgence of that. We would like to cover co-infections like hepatitis B and also cover HIV-2. And also there's still a little bit of a potential to increase the overall tolerability, but I think that's going to be very difficult. However, we sometimes need to switch to something that has a different toxicity profile from the current treatment, and we might have to reduce pharmacokinetic and pharmacodynamic drug-drug interactions. Also increase long-term adherence, and individually adapt dosage intervals and mode of administration, as has been outlined in the previous talk. But also, for prevention, this might be advantageous to simplify pre-exposure prophylaxis and also protect from HPV. If we talk about promising agents, we need to know that we have a lot of agents that were promising in the past. And some of them were discontinued due to lack of activities, others due to toxicity, and a lot of agents just became undetectable with time. So there is no perfect solution probably, and this reflects the evolution of treatment. And as outlined on the bottom of the slide, we already have a lot of drugs that we either have discarded off completely or that we are not using anymore. And I've tried to summarize in this slide all the developments that we currently see that are in phase 1 to 3. And I'll show you the neutralizing antibodies. Some of them are biologicals. As you can see, this is, to orient you, this is the parenteral ART, this is orally administered ART, and the dotted boxes are boxes with drugs that are also being investigated in pre-exposure prophylaxis. And as you can see, some of them are in faint colors. They are actually said to be in phase 1, but I haven't actually found any trials already instituted and recruiting. You can see that we have a lot of agents from the very early steps, and I would summarize the neutralizing antibodies in this case. Although they are passive immunotherapy, I would summarize them as antiretrovirals because they neutralize free virus. From the early events of attachment, post-attachment, host targeting of CD4, which leads to prevention of the conformational changes of CD4 required to bind the virus completely, co-receptor binding, fusion, and then the classical modes of action that we're currently employing. But there's also some focus now on viral regulatory proteins, and there is one idea, I would say, for a PI, an unboosted PI by Gilead, and at the very late stages of virus maturation, the GSK maturation inhibitor. There are also some of the drugs that have not been successful in systemic treatment, like the mixture of neutralizing antibodies shown here, that are now being investigated in topical prophylaxis as PrEP. And that's actually a sound reason to do that, I think, because evolution probably doesn't play a role in this context. But if you then, along my question, take out all those drugs that have some cross-resistance within the class with currently available drugs, actually very few drugs remain with completely novel modes of action, like for Stemsavir, the maturation inhibitor, and ABX464 that only has an RNA suppressive effect at high doses. We see some biologicals remaining, but there are issues with manufacturing availability, and I will come to that later with pricing as well. So in very pure terms, if we want to give something completely new to somebody failing on a current treatment, we couldn't rely on these developments to become available soon and solve all of our clinical problems. If we then add the drugs that only have limited cross-resistance within the group, and sometimes, as in the case of GS9131, are actually specifically developed for tackling resistance, we seem to have a little bit more of options in the future. I have to be a little bit careful about ilselfavrine because the data is very limited and stems. It's a proprietary Russian development, and we don't have a lot of data to say how much is actually non-cross-resistant. Bictegravir, very recently, just about 2 weeks ago, a paper appeared looking at clinical samples, integrase inhibitor resistance samples, which shows that probably the extent of cross-resistance is greater than we think. We could study that by either just adding a drug to a failing regimen, but we then might have potentially suboptimal functional monotherapy. And we could also substitute a failing regimen by just including patients who have a remaining option so that we at least have the optimized background plus one, or even combine 2 or more investigational agents. However, it's going to be a little bit difficult to assess the effect, differentiate the effect then. Or we could, and that's an interesting new attempt, add drugs that have several different modes of action in one drug. Just an example how to maybe solve these issues is the BRIGHT study looking at fostemsavir, the attachment inhibitor developed by ViiV GSK. And they solved the problem by just keeping people on their current failing regimen for about a week, then adding fostemsavir twice daily, 600 milligrams for a week, and then putting people on a boost and on an optimized background regimen, and including a second cohort of people who had no option actually to optimize the background, whereas the others had 1 or 2 active drugs remaining. And as you can see, this results in a relatively good effect. If you look at the strict endpoint of less than 40, it's about 60% of people at week 24 who achieve an undetectable viral load. The other new development that I'm going to show you just to illustrate a problem is ibalizumab, sorry, an anti-CD4 antibody that was studied in 40 patients with triple cross resistance on stable ART. There was a loading dose given, and 2 weekly infusions of 800 milligrams were repeated. You can see 83% of patients had greater than 0.5 log, and the median reduction was 1.1 log. So that looks quite good, but again, that was done by optimizing at day 7, and you can see here that people who were allowed to be included when they received additional fostemsavir because they had no other remaining option, didn't have a really different effect in terms of response, but that probably just reflects the extent of resistance generation in this population. The problem is pricing. If you look at the price for this drug alone, it's probably prohibitive for most settings. One of the examples that I would like to show you is an example that already was mentioned, this EFDA or MK8591, which has a slightly different mode of action, although it looks like an NRTI. It appears to prevent the translocation from nucleotide binding to primer binding site. And it has a resistance selection profile that is non-overlapping with other NRTIs and retains activity against many resistant strains, is active at a remarkably low dose, and has potential for less frequent dosing, even orally, and parenteral application, and also will probably be studied as PrEP. And interestingly, coming back to what I said in the beginning, there is some moderate HPV activity, and it's currently been tested, and that's a little bit of a shame, in naive patients in combination with doravirine and 3TC. Doravirine is an example of a drug that's about to come, an NNRTI that is active against some of the common NNRTI-resistant variants. Unfortunately, again, it's only studied so far in ART-naive patients, with a comparison with darunavir and a comparison with efavirenz, and it shows non-inferiority and a low, in comparison with efavirenz, a low but nevertheless some incidence of resistance. But less of the typical CNS side effects of efavirenz. There are some approaches that are less classical, if you wish to say. One of them is free virus neutralization, and there are developments like VRC01 already in phase 1, with a modification of VRC01 at the FC site, which prolongs the half-life, and as I've shown, the mixture of antibodies, highly neutralizing antibodies for PrEP. Also, there is a new concept of capsid inhibition, which is being developed by Gilead, and also another one by Aviv. And that's actually interfering with structural proteins. And as I said, another focus could be the blocking of regulatory proteins by, for example, ABX464, the case of REF, or DCA in the case of TAT. Probably the effect in terms of RNA of these latency reversal inhibiting agents is probably relatively small, but they might act very well together with other drugs, at least theoretically. And combinectin is an example of combining different modes of action in one drug. Let me just show you that the capsid inhibitor now being investigated by Gilead apparently inhibits the virus at a capsid at 3 different points during assembly, disassembly, and nuclear translocation. And it's active in picomolar concentrations, could be suitable for parenteral administration because it's not highly water soluble, so it's not suitable for oral, and has a potential for monthly dosing in humans. So it seems to be interesting in the context of the new delivery systems. Combinectin is another example. GSK Viv develops this one, and it combines 3 different modes of action, 2 targeting the viral GP41 for fusion, and 1 targeting CD4 binding. And that could, offer the potential of having 2 or 3 drugs in one, and maybe overcoming the problem of not being able to test the drugs in failing patients so well. It's also active in nanomolar concentrations, low nanomolar concentrations, and has a potential for subcutaneous self-administration. So where are we today? I'll show you here that some of the drugs will take a lot of time still, and some are almost already here. Unfortunately, this is all in faint colors. I excuse that. So I think we just have bictegravir is still new for some. It's being used in the US and Europe now. Ilsalfavirin, the Russian development, and the CD4 antibody, as I've shown you. But some of them are about to come. Cabotegravir will also be available in an oral formulation because you need that to introduce the injectables, but it's probably not going to be used on itself as an oral drug. So we don't have such a lot of drugs, as I said in the beginning, and especially from the very new drug classes, that won't solve the problem of resistance if we don't use our current drugs in the right way. The greatest need, as I said, is in countries with the highest rates of failure. The market size, if you wish to say, is greatest there, but the affordability is least. In our countries, in the Western countries, we have relatively few viremic patients with resistance. So the focus with all the studies is probably going to be switching in patients with resistance, so the focus will be more on tolerance and patient satisfaction. And we have the problem that remains a prolonged functional monotherapy, an issue with pregnancy, unwanted pregnancy on ART with experimental agents, especially where the need is greatest. And we encounter the problem that patients actually always prefer fewer pills for earlier lines of therapy, and not everything will be deliverable in this way. For Stemsavir, for example, is twice daily. Too many good alternatives of earlier lines of therapy, so there's a lot of competition there. And we have some drugs, like the Gilead capsid inhibitor, that were actually discarded in the past based on their supposedly unfavorable pharmacokinetic characteristics, which we might have to revisit today in order to see if they are suitable for new delivery systems. Just one final point. I think we tend to forget about HIV-2. There are also a lot of patients infected with HIV-2, not in the Western world, but in developing countries. And not many of the drugs actually are effective against HIV-2 as well. You see them on the left-hand side. Bictegravir is likely, based on one HIV-2 strain. And I've heard some rumor based on the response of Dr. Tse on to his CROI presentation in 2017, where somebody asked if the capsid inhibitor would also work on HIV-2. He said yes, but there is no published information on that. We still have to see if there is any activity. So this is the point to thank you very much for your attention and thank those who shared their slides with me. And I'm waiting for your questions. Thank you very much.
So we have a few minutes for questions or comments before the Lang Van Tongeren prizes for the young investigators are awarded or presented. Does anybody have any questions?
I've been caring for women living with HIV for 25 years, and overall I can say that the severe complications that I have encountered, not only with the chronic disease now of HIV, but also with diabetes, hypertension, epilepsy, is women who stop their drugs because of theoretical fears, always unfounded, with the exception of valproic acid, and they lose control over their disease, and they go on to very complicated, difficult to support pregnancies. I would also like to add that by far the greatest pregnancy wastage from antiretrovirals that has ever occurred was from the false alarm from efavirenz, when for a time women were told to get abortions if they were inadvertently exposed. I hope that we can continue to focus on what is one of the great medical miracles of the 20th century, and that is the development of antiretrovirals and the practical elimination of maternal to child transmission. Thank you very much.
Comment. Thank you. Do you want to add anything on this comment? I think that's about it.
Any other questions?
Okay, thanks all for your attention. Our closing remarks, I think that you have a wonderful presentation. Thanks for the four presenters. We move from what we are doing now to the future. By the near future, I think that we are close to have some drugs. And thanks for me, because you included HIV too. I come from West Africa, and HIV is really a concern for us. So I think that some of us, you are a dreamer, but you still be believer, and you are coming to new drugs, and HIV is a wonderful field where we are moving a lot to have some new drugs and some new strategy and sequencing to tailor the treatment for the patients. Thanks for your attendance all.
And thank you to our four speakers very much.
Yeah. So we have the next meeting now to present the awards.
Yeah.
Yes, the other ones. We are a little bit confusing because we have a next meeting to present the young award, but I think that is another team. Yeah. Let me ask you something.
Good afternoon, and I'm delighted to be here at the prize ceremony. The International AIDS Society and its partners sponsor a number of prestigious scientific prizes in conjunction with the 22nd International AIDS Conference to reward promising researchers who are doing outstanding studies in the field of HIV. More than 35 years in the epidemic, there is a need to foster a new generation of HIV researchers who will be able to support and continue our fight against AIDS. The $2,000 IIS ANRS Young Investigator Prizes are they aimed at supporting young researchers under 35 years of age who demonstrate innovation, originality, rational, and quality in the field of HIV research. The prize is a joint initiative by the International AIDS Society and the French National Agency for Research. For the IIS, in addition to the prize, the Job Lang Institute will support the five recipients to attend the Interest Conference, which was founded 12 years ago by Job Lang and Jacqueline Van Toren Foundation, and which is also known as the African CROI Conference. So, François.
Good afternoon. In 2015, the Young Investigator Prize was renamed in memory of Joop Lange and Jacqueline Van Tongeren in Vancouver. The renamed prize pays tribute to the extraordinary contribution that Joop Lange and Jacqueline Van Tongeren made in the fight against HIV and AIDS. Joop was known for always having time to spend time with young investigators. He would never say no to a request for assistance and mentorship. I'm sure many of us in this room, like me, remember that it was one of its best qualities. So we sincerely hope Joop and Jacqueline's passion and dedication lives are in the spirit of this award to the recipients who can continue the research and ambitious inquiry that ending AIDS requires.
So, let us turn now to the awarding the prizes. The first prize for Track A, Basic and Transnational Research, goes to Shahid Abdullah from the United States for his abstract entitled Reso-CMV-Induced SIV-Specific MHC-E-Restricted T-Cell Recognized CIV through the T-cell receptor. Congratulations. Congratulations. Let's move to the second prize, the Track B. The clinical research goes for Jonathan Chang from the United States for his abstract Persistent Immune Activation and Depression in Rural Ugandans Initiating Antiretroviral Therapy. Congratulations. The third prize for Track C, Epidemiology and Prevention Research, goes to Michael Trigger from Australia for his abstract Changes, Patterns and Predictors of Sexually Transmitted Infection in Gay and Bisexual Men Using PrEP, Interim Analysis from the PrEP-X Demonstration Study. Congratulations.
And now we move to Track D, which is Social and Political Research, Law, Policy and Human Rights. And the fourth prize goes to Kalonde Malama from Zambia for his abstract entitled Prevalence and Predictors of Violence Against Female Sex Workers in Zambia. Kalonde. The fifth and last prize is for Track E, Implementation Research, Economic Systems and Synergies with Other Health and Development Sectors. And the prize this year goes to Francis Matthew Simons from Zimbabwe for his abstract entitled Task Shifting for Point-of-Care Early Infant Diagnosis Testing, Comparison of Error Rates between Nurses and Specialized Laboratory-Trained Personnel. Francis?